Thank you for the kind introduction. Before we get started with today's class, I'd like to introduce myself. Some of you were in my earlier class, already heard this, so you get to hear it again. So my name is Keith Hall. I currently work for RENOVO Solutions. I'm the Director of Service for Imaging. That's my current role. I've got about 26 years in the biomed HTM field. I started in the late 90s. I joined the US Army, and I was a biomed with the Army for 21 years. About 10 years into that, I had to make a decision to be like an Army leader or to remain technically relevant. So I took an opportunity that came up and I went to a program called Training with Industry. And so I went to Phillips Training Campus in Cleveland and I taught their CT repair course for a year. And when I graduated from that, then I rejoined the rest of the troops and I was kind of one of the CT guys for the Army for the next 10 years. When I retired, I came to work for RENOVO as the account director at University of Utah. And kind of by history and qualification, I kind of grew into the role that I'm in now. So I just support all of RENOVO's business on the left half of the country, left third of the country for anything related to imaging. And that brings us up to where I'm from. One thing I did want to say for housekeeping that maybe she didn't mention is if you haven't scanned your badge at the back when you walked in, please scan it. That's how you're going to get continuing education credits for today's class. And the next thing I'd like to say is I thank all of you for coming to my class, coming to this presentation. And hopefully the things that we talk about today you'll find it of value and that you can take back to your organizations and it'll be helpful. And before we get started, I want to do a little quick exercise with show of hands. So just raise your hand if you're on the service side of the HTM industry. If you are a service provider or you work for a service company or if you do service at all. Okay, that's smattering. How about if you're on the clinical side? Work at the hospital, you do clinical, you're like a rad director, you work in radiology, stuff like that. Okay. And I guess everybody else, raise your hand because what are some, like for example, I'm going to poll a couple of folks in the front. What's your role in the HTM industry? What is it? Biomed? Okay. Is anybody here neither biomed or clinical? Show of hands. Couple? Yes, sir. What do you? Purchase services. Okay. And in the back? Capital planning. So I think these, hopefully this is suited to you guys as well. Hopefully you find value in this. Without ado, let's get into the topic of the day. The long version is up on the screen. The short version is how to make your X-ray equipment last longer. Okay. The first slide is imaging device life cycle. You have to forgive me for reviewing my notes over here from time to time. Want to make sure I'm presenting the right stuff. Okay, so capital costs. When you buy X-ray equipment, are those costs trending down? It's getting cheaper to buy X-ray equipment, or is it trending neutral, or is it trending up? Up, so a resounding up. I had two whole people, yes, up is correct. And is technology getting worse, staying the same, or getting more complex? More complex, right? These are obvious things. Maybe it's silly to bring it up like that. Things are getting more expensive. AI is getting involved. Technology is improving very, very rapidly. That's why it's important to talk about the life cycle and end of life planning. That's why it's more critical now than ever. Everything's getting higher. There's more regulatory pressure and complexity. Next slide. Has anyone heard the terms EOL, EOS? Okay. It says it up here on the slide that EOS means the device is no longer the manufacturer is no longer offering parts and service. Before that comes EOL. That's the manufacturer of the equipment saying this device is no longer technically relevant or it's obsolete. Usually you'll get an EOS letter in the mail or an email that says, hi, I'm an equipment manufacturer. We make whatever, mammography devices. In 18 months or so, that device is going to become end of life. And we're letting you know now so that you can start planning. And that's what we're going to talk about a lot in this slide deck, is the planning. Different OEMs have different policies and different timelines. So it's important to kind of read the fine print when you get those notifications. When the device goes end of service, most of the time, I would say in my experience, most of the time, you can't get a service contract on that anymore. They definitely, if you take it off contract, they definitely won't send an engineer out to do the repairs, and they won't sell you the parts. So what do you do then with it? If you don't have a plan, you're going to be kind of held hostage. All right, let's talk about key considerations for life cycle planning. Current system performance and clinical utility. All right, so assessing system performance. Is that device still meeting your clinical needs? Let's talk about maybe CT scanners. CT scanners from 10 years ago could, at that time, do cardiac gated scanning, so they can image the heart, right? They can still do that with the new technology. So has that functionality, that need, that clinical need, is it still being met? That's something that you got to think about. So there's always, sometimes there's a battle where, hey, I'm the doctor and I want the latest and the greatest and the best imaging possible. As key advisors in the HTM community, it's our job to help them understand whether that capability still exists, or the need is being met by the device that's still in service, or if there truly is new functionality that's needed. When you consider parts and expertise, are there still parts available? Are there still technicians that are trained on it? Nuke Med is a great example for this. To the people that are managing rad departments, I'll call on you in the back. We were in the class together before, Miss. How old is your Nuke Med camera? You don't have Nuke Med? Does anybody in the room have a really old Nuke Med camera? Yeah? You got a really old one? How old is it? Over 20 years old, and that's pretty common. Nuke Med cameras, they don't have a lot that goes wrong with them, and they just last and last and last, and they'll stay in service forever. That's why I use them as an example for this topic. But the question is, do we still have technicians that are trained and available to work on those old Nuke Med cameras? And are the parts for those Nuke Med cameras still available? Because the manufacturer's not making those parts anymore. So where do the parts come from? Anybody? Where do parts come from if the manufacturer doesn't make them anymore? Third party, right? And where does third party get those parts? They refurbish parts that came from old machines that got sold, that either got sold for a reason because they weren't working very well, or they came from a lucrative healthcare system that has the money to throw around to buy new equipment as soon as the OEM says that it's obsolete, right? Cybersecurity posture. So does that 20-year-old system run on Windows 11? It doesn't. It doesn't have the latest security patches to be capable for network security on the network? No, right, it doesn't. So those are things to consider as well. Is there a path to upgrade for those older systems? And oftentimes the answer to that is yes. You might have to buy a new computer, put the old software on it, but it'll still run on the newest operating system. And then the cost benefit analysis versus replacement is probably where you may have the least experience, but can add the most value in the HTM community. Taking a look at the cost of a contract, procurement of a new device, and the service contract on top of that, looking at it as a whole, considering the totality of the procurement over its lifetime of 10 years versus finding a way to support the existing device that you have. And I think that what you'll find is more often than not, it's way more cost effective, more beneficial, because lowest cost doesn't always equal highest benefit or the best value, but it is a big factor. So if you can maintain that device and not have to replace it, then that's a great way to go. All right, let's move on. Some of the strategies for extending the device. PM and service planning. If you've got a device that's aging and it's under a service contract, how are you going to do that preventive maintenance when it goes into life if the OEM is not going to extend that contract? Let's actually take a break from that and talk about end of life, end of service. Why do we think automakers, let's just use Ford, don't institute end of life on a Ford F-150? My neighbor's got a Ford F-150 from the like 1980s. It hasn't gone end of life. He can still get parts for it. He could work on it for himself. But in healthcare, that's not the case. Right? In healthcare, the OEM institutes end of life for a couple of reasons. And I would say that one of those reasons is so that they can reinvest their capital into research and development to come out with the next greatest technology, and that's a great reason. I think another reason that they have end of life is so that their technical staff, their technicians, can get trained on the newest revision and work on the newest things. I think that's a really great reason. And I think another reason that end of life, end of support, or end of service, interchangeable, exists is as a sales tool. If I go to the RAD director and I say, hey, that device is no longer the latest and greatest. Oh, and by the way, we're not going to work on it anymore. But if you'd like, you can give us another $1 million or $2 million for the latest and greatest CT scanner, then that can drive sales. Okay? There's lots of reasons behind that. But when it goes into life, what's your maintenance plan going to be? Are you going to do it yourself? Who in here has an in-house biomed team? Your hospital pays the biomed staff. They're direct employees of the hospital and they do all the work. In those systems, does anybody have an in-house imaging team as part of their biomed staff? You do. Does anybody have an in-house team that doesn't have in-house imaging folks? Like you've got an in-house biomed team, but you contract out the imaging to the OEM, or you contract it out to a third party. You guys do in the back. So would you think it's a good idea when something goes end of life to invest in your hospital employees, the biomed department? I'm not asking you as the RAD director to make this decision, just conceptually. Would it be great to take over maintenance yourself? Do you think it would be good to bring in a third party that can come and do the service for you? These are all different options and different considerations that you should think about. And that thought process should start not on the day that the device goes into service, but the day that you get the notification of end of life. That's when you got to start thinking about it. You got probably 18 months to figure it out. We talked about a lot of this stuff already in the previous slide. Third-party parts and service sourcing is what we just kind of talked about on the previous slide. There are reputable parts sources out there, probably over 1,000 different companies you could get parts from. There are disreputable parts sources that you can get out there. Bob's Biomed Garage, if that exists, it's a coincidence. I'm just making it up, but imagine somebody who just goes to auction and buys used CT scanners. And then in his garage, he pulls the parts off of them and sells them, right? Without proper testing, but there are reputable parts providers out there. Look for part suppliers that have a quality management program, like ISO. That's a great indication that they have a quality program and you'll get a quality product from them. Software and security patch management, we talked about it. Do you need to upgrade the hardware to go with the software in order to get the software upgrades? Some of the computers, like on that Nuke Med camera that's built in the year 2005, that computer probably can't run Windows 11 on it. So you'll need a new computer. Capital purchase planning. Okay, so we got a couple of folks in the room that are actually, this is what they do. That's their role in the organization, right? I'm gonna pick on one of them. Sir, is your HTM, your biomed group, a stakeholder in the capital procurement process?
Typically, we have the opportunity to catch 170 independent hospitals. So
okay.
one large IDN
Okay.
So when we run bulk buys and RFPs, we try to make sure that there's biomed stakeholders representing the facilities that receive the equipment.
Okay. Sir in the back, is your HTM program or biomed team involved?
Biomass to they would choose. They have history from finance to
Okay, and so for the biomeds in the room, how many of you, show of hands, know that your department is involved in the capital equipment purchasing and planning? Fewer than I'd hoped, right? And some of it's a so-so, right? And it may be a little off topic, but what about standardization committee? Do you have a standardization committee at your hospital? Right? Like, so let's say the hospital says, hey, we're getting new infusion pumps, or we're getting new patient monitoring. Do you want to standardize so that the third floor has the same monitoring system as the fourth floor, so your med supply warehouse doesn't have to stock different types of ECG leads or patient monitoring accessories, et cetera. So I would challenge you, if you're in the HTM community, whether you're in a position to do it or not, if it's your leadership that would be in a position, or if you are the leader, I would challenge you to engage with the hospital that you support and attempt to get traction. Get a seat or take a seat at the table at the Environmental Care Committee. Take a seat at the Capital Equipment Replacement Committee, whatever it's called in your organization, because your voice matters. You're the technical expert for the medical equipment. And it's especially important in imaging devices because of the cost point. It's way more expensive to buy all this imaging equipment than it is to buy 150 defibrillators for the rest of the hospital, right? Okay. You want to extend the life responsibly. So if you're going to make the recommendation of extending the life, you got to make sure that there's not a patient safety risk when you go to take a look at that. So that's something you want to think about. Next slide. All right, so there are risks of inadequate end-of-life planning, unplanned downtime, and patient care disruption. If you wait until the device goes into service and then the device breaks and you're scrambling to find out who's going to service it, and then you're also going to be scrambling to say, how can we provide the service that this device used to do? I didn't have redundancy for this old cath lab or EP lab or whatever the device is. There was no redundancy. We waited. Now we're down. Now our hospital loses a ton of revenue because that cost center is no longer accruing revenue. We have doctors that we're paying to do those services that are no longer able to perform that service. So it's very, very important to avoid this unplanned downtime and patient care disruption. Regulatory non-compliance risks. So risk of non-compliance with state, federal safety and accreditation standards are on the table if you don't plan ahead. You have cybersecurity vulnerabilities that go up when software patches and operating support stops. So if you're running Windows XP on an old system, you're going to have the potential for breaches. Not every device is going to have a path to upgrade. So that's something else to consider when you're doing your planning. And the key message here is that reactive planning is always going to be more expensive and more disruptive than proactive planning. It's challenging in our field. Like, how many biomeds in here work in a shop that is just overstaffed? You got too many biomeds. Wow, like everybody's hand did not go up. So yeah, that's the case today, right? We've got more people exiting the field than we have coming into the field. So I would share with you, I think it's a challenge to keep one, we have these, most of us have two eyes. I like to keep one eye on what's going on today, tomorrow, this week, this month, this quarter. That's my operational eye, thinking about what are my PMs that are due this month, et cetera. It's good to have a strategic eye. Where do I want my career to be in 5 years? How can I help our organization? Like, if I can use my strategic eye to identify ways that our organization is not doing well and how we can improve that, what are the small incremental steps to make our organization better and what can I do in the next 5 years to get there? That way of thinking is very true when you talk about planning. So it's a challenge, and I'm not saying it's not. It's definitely a challenge to make sure all your PMs are done, all of your documentation is correct, and plan. But when you plan, when you, even if you're an entry-level biomed, when you help plan ahead, it shapes your environment so that you're not chasing your tail every single day. If you just chase your tail all the time, you're not moving forward, you're moving in a circle, right? You're just barely getting those PMs done. So I implore you, use some planning skills, look at things from an operational standpoint and a strategic standpoint.
Problem like, I mean, if you're reactive all the time, like you are chasing yourself, but when it comes to planning, and when you go, EOL ground and you don't have to cross, you just saw it with a major OEM that put out a big recall letter on a lot of new med cameras that were old, and now there's no, like, it stopped scanning, stopped using them, and there's no path forward. It's, well, if you didn't plan, now you're doing something in emergency capital, which really messes up the whole capital process and all of that. So you have to plan at some point, but there is, like you mentioned, a great one, but there is a path to extend, because we, planned obsolescence is a trick, right? So
Yeah.
it's definitely valuable, but you also still have to plan and not just say, okay, we'll just run it to the ground and then figure it out then.
Totally correct. Totally correct. Thank you, Shelby, for adding to that. I'm going to take that as an opportunity to branch off of what's on the slides here and just talk freely a little bit about what he said. So to the biomeds in here, how many of you are in the imaging space? You guys, anybody work in imaging? Okay, a couple. Great. To those that don't, if you're in imaging, I don't want you to answer, but to those who don't, can anyone tell me what the acronym AIAT means to you? AIAT, have you heard of it before? Does it mean anything?
AIAT.
It is, AIAT. Yeah, it's part of 21 CFR. The FDA says all this stuff. So AIAT is assemble, install, adjust, and test. Okay, for a couple of decades now, it's been a rule that original equipment manufacturers have to, they must provide at a reasonable cost to reproduce, meaning if it's a sheet of paper, they can't charge you $300 for a sheet of paper. If it's a thumb drive, they can't charge you $5,000 for a thumb drive. It can be 200 bucks, but it can't be $5 grand. They must provide you, the owner of the equipment, I should say, it's very important. So if you're third party and you're servicing equipment at a hospital and you're not employed by that hospital, you need to have a letter of agency, because it is the owner of the equipment that's entitled to AIAT entitlements. The OEM must provide you whatever documentation, tools, service software, service keys, documentation, whatever you need in order to do those four things. Assemble the device, install the device, adjust the device, and then test the device. So if an X-ray tube fails and the OEM says, well, that system's end of life, we won't sell you the tube, we won't tell you how to fix it, we won't send somebody out there. Two of those three things are okay, one of those is not. They do have to provide you the documentation and whatever service tools, software that you need in order to perform the tube replacement. Now you have to be a qualified person, right? The guy that brings the tube, the FedEx guy, he can't just follow along the documentation and install the tube. You have to have a reasonable background in HTM and have the skill set in order to do it. But here's the other side to that coin. When you require the OEM to, when the FDA requires the OEM to provide that documentation, they also require the installer, the adjuster, the tester to follow that documentation and the output verification. So just because you hung a new tube doesn't mean you brush your hands off and say, hey, new tube's installed, I'm going home, see ya. No, you have to follow the documentation provided by the OEM, and you have to make sure that it meets the specifications that were provided by the OEM. Okay. So that wasn't really part of the slides, but I think it's a key point to talk about while we're here. All right. Do we have any questions so far? Great. All right. So this is a perfect opportunity for Shelby to help me and chime in because he just spoke about it on the previous slide. So we had a nuke med camera that received a recall alert. The organization extended the life of it. They did not have a plan. And that turned into a notification that says, cannot scan, do not use, do not pass go, do not collect $200. That system is done. The only thing you can do with it is store boxes in that room or uninstall the equipment from the room. Right?
Or go against what the OEM says. You're on risk.
That's right.
Customers of our system were ended up in that position of either have to potentially risk patient safety or go get emergency capital for it to start running up.
How do CFOs handle that? They love that when that happens, like unpredictable, like, hey, we need $2 million just out of the blue. Is that pretty good? Yeah.
Side that I stand on is usually
Say-
long throughput halting because of the financial risk for an 8 hours through replacement, you could get sued for double.
What you do?
Reactively buying the money.
Borrow from what you were gonna put in next year. That makes you totally rearrange your whole capital purchase plan. You have a 5-year plan or 10-year plan. All of a sudden, like, never mind, we're not gonna do that CT now that we wanted to do, Q2. Now we're gonna push it to 2027.
Right. It usually gets switched around, especially with imaging equipment, the smaller equipment. Oh, we found money. Sure, yeah. It's case by case.
Yeah, and loss of revenue. And then, oh, hey, Biomed, you know, we were going to buy you that coffee pot, but now we can't afford it, right? Try and drive it home with where it matters.
If I lived and you made a camera on the dock and he installed it.
Yeah. Hey, at least they tell you about it before it's, hey, this got installed last week. Can you go take a look at it? Or you notice it when you're walking around. All right. So we're going to talk a little bit about the role of service engineers and clinical teams, because really it's a partnership. All the people in this career field, everybody in this room, I may be going too far, correct me if I'm wrong, but the folks in this room, you get up, you put on your nice outfit every day and you go to work for mostly one reason, and that's positive patient outcomes. Am I going too far? Is that pretty accurate? All right, we're here for that person who's having the worst day of their life. They're in the hospital, they need health care. So we work together as a team. And I will tell you that I feel like service engineers are stewards of the equipment lifecycle. The service engineers are the first to identify risks as well as opportunities. That's what we do. We're kind of trained into it, assessing how the device is working. Hey, I noticed this. That might be something I need to escalate and raise a concern about, etc. That's not to say that our clinical staff doesn't as well. I just feel like sometimes maybe I feel biased because I'm a service guy. We have more of a keen eye for looking for those type of risks. So collaboration is key between radiology, IT, biomed. We've all got to be aligned on what our goals are and working, rowing the boat in the same direction. It's no good if your biomed and your IT are rowing one way, but the clinical staff is rowing the other, or vice versa, any combination of that. Proper training and documentation really empowers the teams to manage the assets after the OEM. So when you get that first notification, that's the time. Make sure you've got a plan. Are we going to do it ourselves? If so, how are we going to get the training? Is that training good training? Let's get the training now at notification, even though that thing's under contract. maybe for the next 18 months, my trained engineer can shadow the service engineer who comes in and does the work, get a little bit of hands-on. Maybe we can transition the current contract that's full service to a shared service contract. So our engineer can go and do the first look and do some of the repairs. Maybe we can shave off some of the cost of that contract. Okay. Encourage technicians to take ownership and lifecycle management decisions. Next. Collaborating with OEMs and third parties. So the equipment owner will be key in negotiating service continuity or transition. And in order to do the best job of that, there's got to be open lines of communication between the equipment owner, the OEM that made the equipment, and whatever your service platform is. If your service platform is in-house, third party, whatever it is, you got to have those open conversations. If you opt to go with a third party vendor, please be selective. Please, these are patients' lives at stake. Go with a company that has a good reputation, that has a quality management program. Please don't go over to Bob's Biomed Garage. You know. And service literature, service tools and training. Manuals, service tools and training are critical for independence. The time to negotiate for service tools, training, and literature is not at the end of the device life. So in my previous life, I was in the Army. So I'm gonna tell a little quick story. In the Army, our contracts always, for at least for the 21 years I was in, every time we procured a medical device, it was in our contract as a standard that we would receive 2 copies of the operator literature, and we would receive 2 copies of the service literature. Has anybody bought an imaging device lately? Been involved in it? Do you get copies of the operator literature? Probably, right? Because you need to know how to use it. And you get an in-service, you negotiate for an in-service. Do you think you get a copy of the service literature with service passcodes and service keys and how to install the things? No, right? Because that's where the OEM is going to make money, is on those service contracts. And the more that they can withhold that kind of stuff, the less you can self-perform and save that money, or the third parties would have more difficulty self-performing. So I would challenge everybody in this room that's a stakeholder in equipment purchases, request everything you can get from the OEMs at the time of purchase. Oh, GE, you're offering me this. Well, I was thinking about maybe I'd go with a Canon instead because they're going to give me X, Y, and Z. It's your time to negotiate, to set yourself up long-term for good service. Have the training that you need. Get that training in as part of the contract. Point of sale service contracts can help you reduce the cost of the initial purchase of the equipment. That's a great option. Or you can say, we want to perform this ourselves and pay a little bit more up front, but save 5 times, 6 times what you paid extra throughout the course of the life of that device. Just be smart about how you negotiate and think about these things. And if you're not the one that is negotiating, maybe buddy up with those that do the negotiation and work it as a team. It's got to be a partnership mindset rather than adversarial when you approach the OEMs about this stuff. Okay, we're getting close to the last couple of slides here. Let's talk a little bit about the future. Trends, modular upgrades, remote diagnostics, predictive analytics. They're all going to reduce downtime and they're going to ease upgrades. There's people in this room that develop tools that are great at some of this stuff and offer them to the market. If you want to know more, you can talk to me about it after this class. It's getting easier to remotely monitor, view logs, diagnose problems, show up on site with the parts that you need already in hand, or have the part you need shipped directly to the site. Predictive analytics will shift maintenance from reactive to proactive. Imagine a world where we have a database of every X-ray tube in the world, okay? And every model of every X-ray tube ever that's in existence out there all feeds into some big giant database. This is all make-believe, this doesn't exist. And somebody can analyze all that data. Maybe even AI can analyze that data. And they could say, oh, a Philips MRC tube lasts X number of scan seconds, right? 1.1 million scan seconds, 90% of MRC tubes fail. I'm making that up. That's not the real number, just saying. Well, then you can shift from that fire drill that we do whenever a CT tube goes down, right? Now we're next flight out shipping X-ray tubes, and the engineers are working from 8 o'clock at night through 8 o'clock in the morning, and the hospital's all upset because their equipment's down, they're on divert, everybody's upset. There's real risk of patient life being lost due to the hospital being on divert. We can shift that to say, oh, well, we're at 1.05 million scan seconds. Let's go ahead and replace that tube proactively. How does Tuesday night at 7 p.m. sound for you? And the rad director comes back and says, can we do it on Wednesday night? That's actually our lighter evening. Sure, we can do that. You can have the tube shipped ground. You can have schedules blocked. You can have a proactive approach rather than reactive. The right to repair movement is growing. It's just going to get better, I think. That's my prediction. Right to repair will improve. AIAT is a big part of that. That stands, what does that stand for again? Somebody show a hand who's brave enough to, what do you got? Nice, good job, Travis. You were listening. Very well done. Yeah, so that's gaining momentum. I think that the right to repair is moving in the right direction. Say it again. 21 CFR, and it's chapter 800 something, 820.10b. That's off memory. That's probably wrong. I'll look it up though and let you know. Okay, and clinical engineering role, I think the biomed's role is going to evolve from where it is or has been historically as repair only into a strategic asset management type role. More than just break fix, more than just knocking out your PMs. I think that if you want to grow and develop and elevate your role as in biomed and HTM, consider ways that you can engage as a strategic asset manager. So these are the key takeaways. Proactive end-of-life planning and strategic asset management. We talked about this. Life cycle extension, excuse me, reduces the total cost of ownership. And I have some actual examples that I could talk about that after this class if you'd like to hear some. Service teams, they've got to be empowered and well-resourced in order to do that. Like if you don't have, if your clinical engineering team doesn't have a seat at the table, how are you going to help make these decisions or make recommendations or provide information that the decision makers can weigh when they make those decisions? Capital purchase equipment planning and new service strategies should be completed between EOS and EOL. I think we've talked about that before. I would just say that EOL planning is not optional. It's a core part of managing the assets that we are responsible for. Lifecycle extension lowers the total cost of ownership while ensuring clinical continuity. We were talking about empowering our folks. A well-trained service team is the backbone of successful end-of-life strategies. And being proactive really protects patient care, compliance, and organizational finance.